This conference will now be recorded.
American
This
Board Certified
conference will now be recorded.
AB Vascular Neurology, stroke specialist, and we are extremely happy to involve you in this session, sir. And thank you for giving your valuable time since last couple of days. It has been wonderful to listen to you and share your knowledge with us. Thank you, sir. I now hand over the mic to Dr. Sushruth to continue the proceedings of today's session. Thank you, sir.
Thank you. Since the topic is vast, I'll just get on to the point. So today we'll be discussing about seizures. It's whenever you see a patient with status epilepticus, it doesn't matter whether the patient is on the floor, is in the casualty or ICU, pretty much the management remains the same. So to begin with, there's a historical definition of status epilepticus. Whenever the seizure lasts more than 30 minutes, then that constitutes status epilepticus. And most of the time, they don't regain their consciousness. So whenever you see this, patient is already classified as status epilepticus. This was the historical definition. But practical definition is that whenever there's a seizure which is continuous for more than 5 minutes, this can be considered as a status epilepticus. Or if there is 2 episodes of seizure and in between patient did not recover the consciousness or this incomplete recovery, then also that is considered as a status epilepticus. Whenever you see this, this is a very clinical and practical and operational definition. This will save you from patient entering the refractory phase. So whenever you see a patient with seizing for more than 5 minutes, aggressively we need to follow the protocol for status epilepticus. As you're aware, the incidence varies from studies to studies of status epilepticus, but in general, around 7 per 1 lakh patients suffer from status epilepticus. And majority of these patients who end up in status, they either have epilepsy in the past and they have been on drugs, and most of them are epileptics who enter this phase of status epilepticus. Regarding the etiology is concerned, most of the time there be brain injury. An acute scenario, a stroke patient can end up with status epilepticus, head trauma, subarachnoid hemorrhage, any kind of anoxic brain injury, or infections, which we see very commonly, or even tumors can present acutely as status epilepticus. In patients even with chronic brain injury, they can also end up with status epilepticus, and those patients can be prior head injury and there is a scar tissue. Then there are previous neurosurgical procedure done on the patient and developed scars. So any AV malformations or cortical malformations, they all can lead to seizures and status epilepticus. Also, we see very commonly patients coming with status epilepticus, and when we ask history, they were on seizure medications, but for some reason they discontinued it, and that might be the other cause for status epilepticus. Also, we see patients who are on alcohol or they are on some other medications for sleep, and they stop the medication without their realization, and they can end up with status epilepticus. Also, very commonly, we see patients who have hepatic encephalopathy, who are uremic, or if the blood glucose drops very low, or if the blood glucose went up very high, they also can end up with status epilepticus. There are 4 electrolytes which are notorious to cause which causes status epilepticus. The 4 electrolytes are sodium, calcium, then there is magnesium and phosphorus. These are 4 electrolytes. Then metabolic wise, glucose is a very important key factor which can cause seizures, either very low or very high. Regarding the drugs are concerned, we use tramadol pretty frequently, and we use penicillin and beta-lactam antibiotics, and notorious among them is cefepime, and also bupropion is a very highly used drug as well. And then other drugs like metronidazole and a lot of other medications, tricyclic antidepressants, and can all cause status epilepticus. But from my ICU experience, tramadol, cefepime are the most notorious ones, which pushes the patient. This is more common in patients who are seizure patients, but even non-seizure patients, when they are on tramadol and cefepime, they end up with status epilepticus. Then there are other rarer causes of status epilepticus, like autoimmune encephalitis, especially NMDA receptor antibodies and voltage-gated potassium channel antibodies. Those patients also can lead to can end up with status epilepticus. And then there is thyroid disorders and lupus and other conditions and intracerebral hemorrhage. They all can lead to status epilepticus. Regarding the status epilepticus, it can be either generalized or it can be focal. So when you have generalized convulsive status, then they can be primary generalized or they can be secondary generalized, which means that there is a focal onset and then it spreads to the whole brain and then it becomes generalized. And then there are other conditions like myoclonus, tonic-clonic seizures, which all can be a variant of status epilepticus. Then there is focal status epilepticus, which is called as epilepsia partialis continua. And we see that rarely, but it does occur. And we need to be aware of this. But also, you need to be careful about an entity called non-convulsive status epilepticus. This non-convulsive status epilepticus, majority of the time, you see them in ICU scenario. You get a patient who is seizing, you give medications, patient is drowsy, you think that patient probably is post-ictal, or whether patient is like having the medication side effect, or patient is tired, or due to other medications that he's drowsy. But after 1 day or 2 days, patient is not waking up. So then you do a EEG and you see, for your surprise, that patient was seizing all the way through. So this entity non-convulsive status epilepticus, you need to be careful. We have to identify this early because first of all, non-convulsive itself shows that patient prognosis is poor. So the earlier we intervene, better for the outcome. Now, regarding generalized, the types of, we talked about types of convulsive status epilepticus, it can be generalized. And when it's generalized, everybody is seeing that patient is seizing, patient will have either tonic phase or clonic phase or both. And that is very easy to recognize and it's not a major problem. But it is a very serious complication, very high mortality, morbidity if you don't intervene. Then there is focal motor status epilepticus, and I have mentioned before the epilepsia partialis continua, and they are sometimes refractory to treatment. There will be prolonged, persistent jerking activity. Sometimes it can even last months together. And sometimes it can be secondary to either some infection or scar tissue in the brain, it can be due to vascular lesions or neoplasms. Rarely, it can be due to some autoimmune conditions or Rasmussen encephalitis, where the patient has, it's a very rare form of epilepsia partialis continua. It usually there will be one side of the brain will be atrophied and patient is seizing all the time and patient will be showing plaques on the EEG. And it's a very difficult condition to treat. Then you have myoclonic status epilepticus. Myoclonus is a jerky activity which can be rhythmic or non-rhythmic. And this patient can be either focal or generalized. When it's a benign condition, the juvenile myoclonic epilepsy falls into this category, and that can be treated. And there are other conditions which can cause JME-like symptoms, which can be Down syndrome or Lennox-Gastaut and other conditions. And this is not malignant. However, when you see myoclonus secondary to anoxic brain injury, that's the time when we are in trouble. It's a very difficult condition to treat. No matter what you give, as soon as you stop the sedation or propofol or other medications which you are trying to suppress, and patient is on multiple drugs, as soon as you stop or reduce the dosage, patient will be having this myoclonics. So especially this we see in a significant anoxic brain injury, like either hanging or prolonged cardiac arrest scenario, and so on. In patients with metabolic disturbances, the uremic or hepatic encephalopathy or respiratory failure, we can see that, but those are easy to treat once you correct the identifying underlying medical condition, metabolic state. Many times we are successful in bringing the patient out of this. The EEG will show erratic movement. It can be rhythmic, as you see on the right, and it can be it can be non-rhythmic. So it's very the EEG is all over the place, and EEG usually it doesn't actually reflect the outcome. There will be a lot of EEG changes which looks ominous, but patient outcome might be better as long as you identify the patient early and treat the patient. Regarding the imaging is concerned, obviously you should have an imaging of the brain whoever comes with status epilepticus, and you can get a plain CT head, but the most important imaging modality would be brain MRI with contrast, because structural brain lesions, or if there's infection, inflammation, they all are better identified with an MRI brain with contrast. So if you are doing a MRI brain, please do it with contrast. As you can see in this picture, you see this sulci gyri, there's a little bit of a signal changes. This is the classic for patients arising, like especially in focal seizures, status epilepticus. You can see this patient is having some restriction in one part of the brain. But then if the patient seizures are extremely generalized, then you can have sulci gyri signal abnormality in bilateral hemispheres. Coming to the treatment, with any patient, the supportive care is very crucial. If the patient is coding, you need to quickly jump on it and maintain the airway breathing circulation. And the most important treatment you give at that time, along with the ABC, is benzodiazepine. You use lorazepam as soon as possible. And then at the same time, you know that patient is in status epilepticus, plain benzodiazepine is probably will not be sufficient. So you're already planning for a long-term control using a non-benzodiazepine anti-seizure drug. As I've just mentioned, you need to have a general neurological exam. You need to get a history. History is very crucial, because if the patient had trauma, if the patient has any fever history, if the patient is on alcohol, if the patient has taken any recent medications, these are all very important to identify the culprit so that we can take it off from the equation so that the outcome is better. Now, also, if the patient is in withdrawal, just treating seizure might not be enough. You need to address the withdrawal component as well. So history is very crucial. And also, regarding the blood work is concerned, I said before, 4 electrolytes are crucial. And many times we see hyponatremia as the usual culprit. And also sometimes in the recent past, I've seen many patients, even hypocalcemia and hypercalcemia, coming with seizure. So 4 electrolytes, sodium, calcium, magnesium, and phosphorus are crucial. And then obviously you need to check every patient's glucose. Any neurological condition, you are checking the glucose. And also you are going to do LFTs to make sure patient doesn't have hepatic encephalopathy. Renal function should be checked. And also if the patient is already on seizure medications, the levels can be sent. And sometimes this level, sending the levels might be a little bit tricky depending upon the availability, but that should not prevent you from doing the right thing. So that is, if you have it, it's good. If you don't have it, you have to use your clinical judgment. In some scenario, you need to also send drug screen. You also do the TCA levels and so on. So drug levels of other medications needs to be done, not only anti-seizure medications. So that's also very crucial. And sometimes even recreational drugs can be involved as well. And also, if you suspect the patient is secondary to alcohol issues, you better give thiamine along with blood glucose, because it can prevent further damage to the brain. Now, the initial therapy, I've said just now, abortive therapy is lorazepam. You can use like 0.1 milligram per kilogram. Normally, we give like 0.5 or 1 milligram because you're concerned about airway protection. But when the patient is in status epilepticus, that is least of your concern. You need to have the crash cart ready because guarantee this patient is going to get intubated. More than 80% of status epilepticus patients get intubated. So you are already ready with the crash cart. So it doesn't matter, your main intention or your goal is to stop the seizure. So you can go up to 5 to 6 milligrams of lorazepam and bolus. There is no issue. So this is very crucial because you please do not, again I'm repeating, please do not worry about airway. As long as you have a crash cart ready, and if you have people who are experienced to intubate, go ahead with this. If you do not have a patient, people who are trained in intubation and so on, even then you have your bag and mask, you can still go ahead. So please do not wait for somebody to arrive. You can go ahead with the treatment. Now, you wait at least 3 to 5 minutes before you give additional doses of lorazepam. By the time you feel that that patient is not stopping with this loading dose of lorazepam, you already know which path you are taking. Patient is going to get intubated. Patient will be ending up with multiple seizure medications. In the next thing you do is you are going to give fosphenytoin or valproic acid or levetiracetam as your second line treatment. Now, the medication dosage is very crucial because if you underdose the second drug, then you are not successful in aborting the seizure as well. So you would choose like 20 milligram, 15 to 20 milligram of fosphenytoin is a very decent dosage. And you need to administer at 10 to 100 to 150 milligram per minute because phenytoin is a much toxic drug than fosphenytoin. So that should be given much slower. But with fosphenytoin, you can be a little bit faster. Now, the most important key thing when you're giving fosphenytoin is to keep a close watch on the blood pressure. That's the only thing you need to watch. Usually it doesn't cause arrhythmias, usually it doesn't cause any other anaphylactic shock or anything. But most important side effect of fosphenytoin is sudden drop from like 200, the blood pressure drops like 80, 60, like that's systolic. So you need to be very, very, very careful with fosphenytoin. The second drug, not second drug, but another alternative is valproic acid that is given at 30 milligram per kilogram and administered at 10 milligram per kilogram per minute. You might be surprised with the levetiracetam. Actually, even I was surprised because this is all recent change in the guidelines because we normally load the patient with 1.5 gram of levetiracetam. That's the usual extent we go, and then we start like 1.5 grams twice a day. But they are saying that you have to give, the recent guidelines are saying you need to consider 60 milligram per kilogram and maximum dosage of 4.5 grams. So this is a pretty extensive dosage, and they want to load the patient just like fosphenytoin and valproic acid. So this is a new thing which needs to be taken into consideration. Now, if the patient is not responding, then you can use the second drug or you can repeat fosphenytoin. But when a patient is not responding to the first drug or the second line of treatment, you need to bring the next drug online. So for example, if the patient received the benzodiazepine, not responding within a couple of minutes, you're starting either fosphenytoin or valproic acid or levetiracetam. And if they're not responding, you can use the other drug. Either if you have used fosphenytoin, you're using valproic acid. If valproic acid is not, you have used it, then you can use levetiracetam, so on. So you're already using that. Now, we usually, if the patient is not responding to the second drug, we are not waiting for a long time. We are going to bring the third drug also. By the time patient is intubated, and you are going to bring other drugs which will abort the seizures right away. For example, propofol or midazolam and so on. So once you cross the second stage, you already know patient will probably be on the propofol. This is my clinical practice. As soon as I give the first drug, patient is not responding. I'm talking about after the benzo, you're giving either fosphenytoin or levetiracetam. My next choice would be propofol because I want to abort the seizures right away. So I would quickly intubate and start the patient on propofol. and we usually use bolus and so on, but we are going to discuss about that in a couple of minutes. Also, patient should be intubated and should be on ventilator and should be in the ICU scenario, because in the casualty you'll not have all the equipments to handle these things. And also there can be sudden drop in the blood pressure. You need to be keeping a very close watch on this. And also cardiac monitoring is very crucial, because many of these patients will have electrolyte imbalance. So you need to make sure that the potassium and everything, calcium and everything is monitored, because they can go to arrhythmias if they're low. And so you need to keep a close watch on that. So once the patient is not responding for these traditional two drugs, then you already know patient is in refractory state. So this is called as refractory status epilepticus. So at that time, you should think about whether we should do continuous EEG monitoring. Now, some people might say, oh, we don't have resources for continuous EEG monitoring. It does not matter. You don't have to worry about continuous EEG monitoring. As long as clinically patient has stopped seizing, then you can do a EEG in a stat basis, like in the next, like an hour or two, and you can do just a short EEG monitoring. The main thing what you want to know is whether patient is in non-convulsive status or not. That is the reason why we need EEG monitoring. And if you have a continuous EEG monitoring, that will be great. But if not, at least an EEG would be very helpful. My practice is when a patient is in status epilepticus, I would like to get the EEG in the first 1 hour, because that is where I want to know whether patient is in non-convulsive status or not. If the patient's EEG is fine, if it's very slow, nothing to worry, then you have won the battle. Now the next thing is to go to the next step. So when the patient is in the refractory state, you would choose either midazolam, propofol, or pentobarb coma. Either of these three drugs you use to put the patient on coma. Propofol is my favorite, but it doesn't have to be. You can choose whatever drug among these three. But why I say propofol is, from my experience, it works really well. It kind of slows down the brains very fast, and you can do the bolus of 1 to 2 milligram per kilogram loading dose over 5 minutes, and then the rest of it you can go rate. You can go up to 10 to 12 milligram per kilogram, and you can use 25 to 50 milligram per hour without any issue. And so usually it does the trick. The other option would be midazolam. I use midazolam especially in patients who I feel they're alcoholic withdrawal or alcohol-related seizures. They respond very well for when they're in status for these benzodiazepine. Then the next option, the last option, would be the pentobarb coma. It's a traditional drug. It's a very old drug, but it's very helpful in some refractory cases. One thing I need to highlight is, since you are using drugs whose levels can be measured, you make sure that you monitor the phenytoin level or phenobarb level or even levetiracetam levels, or valproic acid levels, so that you can optimize and reload them if the levels are low. Now, further management. Now, when we choose the anti-seizure drug, you have to take a lot of factors into consideration before you choose the drug, because if the patient is having alcohol issues, or if the patient is having liver problem, if the patient is in renal failure, so you need to avoid medications which can cause these or worsen the current comorbidities. So, and with your experience and with the local availability and the potential of adverse effects, you're going to choose which drug to choose in the long run. Now, there was an established status epilepticus trial, and they looked at 384 patients, and they compared levetiracetam with fosphenytoin and valproic acid. The conclusion was, among the anti-seizure drugs with the IV, both all three of them, fosphenytoin, valproic, and levetiracetam, were equally effective, and they have similar rates of adverse effects. But you should understand that hypotension was more common in fosphenytoin group, whereas more mortality was seen in the levetiracetam group. However, these were not statistically significant. So you should not be nervous using one drug over the other. You can choose any of these three drugs in the first phase. Also, lacosamide is also coming as IV. So this again it's a new drug relative to the other three drugs. and they have similar efficacy, and you can give bolus of 200 and then maintenance of 100 BID would be very effective. And when you combine it with levetiracetam, it's a very it's very effective combination. And in my experience, I usually use levetiracetam and lacosamide as my initial choice. The reason I'm choosing these two is not because of my personal preference, but I'm thinking about long term, because I don't want even my family members on phenytoin or valproic acid, because more cognitive side effect, and especially in the elderly patients, it's extremely toxic drug. And the interactions with the other medications, because when you're elderly, you're on a bunch of other cardiac medications or any other medications, statins and so on. So the interactions is very high. So if you have some combination which is giving you equal effect, why not choose this, is my logic. So, and I have been using this for almost now like what, 15 years, and it's very effective. So you can try in your practice and see how it works. And then you have other drugs, phenobarb and topiramate and clobazam. But topiramate, as you can see here, up to 1600 milligram, you need to show the efficacy. So it's a very, topiramate, as you are aware, is a very toxic drug in a high dose. So in order to achieve it, you have to use such a high dose, and it's not IV. So it's a little bit tricky. But other medications are also there which you can use through your nasogastric tube, like clobazam and so on. Then you have myoclonic status epilepticus. You need to be careful in this condition because phenytoin and carbamazepine should be avoided because it can worsen the problem. The most effective drugs are levetiracetam, benzodiazepine, and valproic acid, and they are very good for myoclonic jerking. So 20% of status epilepticus end up as refractory seizures. Now, especially when it's involved anoxic brain injury, it's very high possibility. So they looked at these patients with status epilepticus, and they found out that 52% of patients, their symptoms resolved. And EEG were showing it can either be normal or it can be showing some periodic discharges. And mortality was low at 13%. Whereas in 14% of these patients ended up with non-convulsive status epilepticus. They were comatose, and the mortality was more than 50%. Now, 34% of them, they can have some intermittent quality. They can be semi-comatose, and EEG might show some problems. And in those patients, mortality was around 32%. So basically, the best group were patients whose seizures stopped and they had a better outcome, whose EEG were also reasonable. In patients with non-convulsive, that prognosis was the poorest. Their mortality was more than 50%. And interim group, the mortality was 32%. So the optimal treatment for refractory status is very controversial. Each person have their own style of managing, but propofol, midazolam, and pentobarb have been used. But mortality can be very high. I just mentioned about propofol. It's initiated at 1 to 2 milligram. We talked about this, and it's very useful. And almost everybody in the ICU scenario are very well versed with propofol. It's the bread and butter of ICU care. So a lot of people are well versed. However, you need to be careful if it is used for longer duration, like more than 24 to 48 hours. You have to keep a very close watch on the renal issue, ABG because of lactic acidosis and metabolic acidosis, and also CPK as well. And also you can see very high triglyceride levels, and that especially when combined with other medications, then especially statins and other medications, the chances of triglyceridemia is very high. And also you have to keep a watch on the amylase and lipase as well. Now, how long you are continuing these continuous infusions? Well, usually 24 hours later, you are going to slightly cut down on the rate and see whether the patient wakes up, or you see whether the patient has clinical seizure. If there is none of them, and if the patient is showing some progress, then you are going to slowly titrate down the dosage of these medications. However, having said that, by the time patient should be on the medications like the long-term seizure medications, Either it can be levetiracetam, it can be valproic acid, or it can be fosphenytoin. Patient should be on that, because if you stop these infusions without that cover, then you are going to end up with again status epilepticus. Regarding the prognosis is concerned, status epilepticus can be very high mortality. Anywhere when it's the first episode, that mortality can be up to 20%. But after anoxic brain injury, mortality is very high. Almost when we see a patient with myoclonic jerks and status epilepticus, then in secondary to anoxic brain injury, after 48 hours, we are going to explain to the family that we are looking at a very high mortality, more than 80%. So it's
Hello.
Hello, sir. This sir is not audible. Vishnu sir. Hello.
ಎಲ್ಲಿ ನಾವು ಸ್ಟಾಪ್ ಆದ್ವಿ ಅಂತ we should just continue. Okay. So as I was talking about mortality, mortality depends on the etiology in most factors. So the higher the comorbidities, higher the age group, higher the Apache score, the mortality is much higher. Now, also, I mentioned before, when a patient comes in with status epilepticus into the casualty, my priority is to quickly stop the seizures, because every minute we leave the patients to seize, you're ending up with a severe neurological deficit. The brain is getting fried. So we need to quickly abort the seizure activity, because 10 to 50% of survivors are left with significant disabling neurological deficit. So just like any stroke patients, especially time is brain, same logic applies in status epilepticus. Time is brain. We need to quickly abort the seizure activity. Now, choosing an anti-seizure drug. Well, there is no particular drug of choice in every patient. Each person is individualized. So you need to think about the potential adverse effects, interactions with other multiple medications the patient is already on, comorbid medical conditions like especially renal and hepatic and cardiac, and including age and gender as well. Also very important is the cost, because if you give a costly medication, patient will be non-adherent and you are ending up putting the patient into status epilepticus invariably. Now, regarding the choice of drugs, you have bunch of drugs. As you can see, you have brivaracetam, which is new drug in the category of levetiracetam, clobazam, felbamate, lamotrigine, levetiracetam. You have topiramate, valproic acid, zonegran or zonisamide. Then you have other drugs like the older ones like carbamazepine, you have phenytoin, phenobarb, and so on. So whenever you choose a drug, try to see whether you could choose something for long term so that the patients will be benefited in that aspect. Now you can see this is the side effects of each one of the drug. This is just for your information because you cannot potentially remember each one of the side effects. But just to kind of commonly tell you, Keppra or levetiracetam usually causes angry reaction or behavioral changes. That's very common, which will be very much aborted by adding vitamin B6 or pyridoxine. We do it all the time. If you take valproic acid, you need to be concerned about platelets and ammonia levels. Same thing with the topiramate, you need to be concerned about ammonia and platelet levels. And so each one have their specific, and if you choose oxcarbazepine or carbamazepine, you need to be concerned about sodium. And if it's carbamazepine, you need to be concerned about drop in the white cells, sore throat, and so on. So you need each medication have like a typical side effect. If you remember one or two of them, that will be fine. But majority of these medications causes drowsiness, dizziness, headache, imbalance issue, because it's kind of suppressing the brain. Obviously, you're going to get these side effects. And when you combine one or two drugs, that's when we are in trouble. Now, there is a lot of debate about monotherapy versus combination therapy. In ICU, our goal is to stop the seizures. Our goal is to prevent any second episode of seizure. So sometimes we can go overboard and try different medications at the same time. But preferably, it is better to put a patient on one single anti-seizure medication and optimize the dose to the maximum before you can consider the second drug. So if you give, it is just like, the logic is just like using 3 antihypertensive therapy at a suboptimal dosage. Same logic applies to seizures too. If you use 5 milligram of lisinopril, amlodipine 5 milligram, and another medication of like a lower dose, instead of that, I would rather use full dose of lisinopril or amlodipine and see whether that helps. Same logic applies here. Try to use one drug, but in status epilepticus, same logic might not apply to begin with, because patient is seizing, your priority is to stop seizures. You can try to use 1 or 2 drugs, but if the patient is not in status epilepticus, preferably use one single drug in a maximum dosage. Then you go to the next drug. That will help with compliance, cost as well, and fewer idiosyncratic reaction, as well as the drug interactions. All these things are prevented, and especially in pregnant patients, that will lower the incidence of teratogenic events. For example, carbamazepine have significant interactions with different drugs. You cannot predict how it's going to monitor. Carbamazepine can lower the effect of the other seizure medications, or carbamazepine side effect can be increased when you combine with other medications. So better to choose the right drug and one drug is to begin with, and then you can add the second drug. Now, regarding the medications, my personal choice, again, it is left to person's individual experience. My personal choice would be to use the newer drugs rather than the older drugs. When I say newer drugs, levetiracetam and above means either the oxcarbazepine, levetiracetam, or even for the matter, brivaracetam, even topiramate or clobazam, and so on. But I would reserve phenytoin, Depakote, and other valproic acid and other medications for much worsened refractory seizures. Just to summarize, this is just, we are almost finishing. So if a patient comes in with first episode of status epilepticus, there's no question patient should be treated. But if the patient comes with just one episode of seizure, and this was the first episode, you don't have to treat unless the patient has structural brain issue, or if the patient had any other compelling factor for you to treat. So for first episode of single simple seizure, you don't have to treat. But if you have recurrence, obviously you don't have any choice. Then also initiate anti-seizure medication in monotherapy compared to combination therapy. Also, when you have the first ASD is unsuccessful, adding a second drug is definitely recommended. However, the chances of having successful resolution of seizures as you go on adding subsequent drugs are very less. So the more drugs you are bringing on board, the patient is already telling that his seizures will not be very well under control. So when the patient is not responding to one or two drugs, then adding third, fourth, fifth drug, you might not be successful in at least on 25 to 30% of patients. Also, it's very important for the patient's education, compliance, and also you need to have a regular outpatient visit so that patient is compliant, so that we can avoid this deadly complication of sudden death and status epilepticus. Patient should be educated about sudden death syndrome. That is one of the it's a mandatory that patient should be educated. Every seizure patient should be educated about sudden cardiac death, because this can happen in patients with seizures, and also in patients with women of childbearing age. They have to be told about the possible teratogenic effects from the medications. Notorious among them are the valproic acid, and so you need to be very careful. And also sometimes when they're using oral contraceptives, these medication, the seizure medications, can reduce the efficacy of oral contraception, and people can get pregnant, and it can be a medical legal aspect as well. So you need to educate them about alternative forms of birth control. And also sometimes suicidal thoughts can happen, depression can happen with seizure medication. You need to keep a very close watch on that too. Now, as I've said before, patients should be educated about sudden death syndrome, and they should be told about restriction of driving. The normal guidelines, it varies from person to person, but majority of the time we tell them not to drive for at least 3 months seizure free, and they should be compliant on medication. They should not have any seizures for first 3 months. Then you can probably allow them to drive. But there is no guidelines here, so you need to be careful. So you need to educate them about driving, because they will not even kill themselves but kill others too. Sometimes people ask when they can stop the seizure medications. Well, some people advocate for 2 years. If they don't have seizures, then they can try to taper down and stop. People with seizures, majority of them, they have some or the other structural brain issue. In those cases, I won't stop it, because any insult like dehydration or infection or any other drugs, medication can provoke the scar tissue and cause seizures. So if a patient has significant abnormal EEG, or if the patient has abnormal brain imaging, I won't stop the ASD, even though if they're seizure free for 2 years or 5 years, doesn't matter. This is my clinical practice. I'm going to stop at this juncture because there might be a lot of questions. So if you have any questions, I'm open for those.
Thank you, Dr. Sir. Dr. Vinayak, a renowned neurosurgeon, ex-associate professor, JSS, visiting consultant, Gopal Gowda, and many hospitals in Mysore. Sir, would you like to add on to any points to this present discussion, sir? Dr. Vinayak, sir? Sir, your mic is muted. Sir.
Yeah, most of the things are covered. I don't think so anything else is required to manage status. Everything is being covered.
Yes, sir. Yes, sir. It's extensively covered.
Yeah.
Yeah.
Extensively covered.
Opening for a discussion now. People with any doubts or clarification, questions, please come forward.
Hello. Hello. Hello, sir.
Hello?
Yes, sir. Yes, sir. You are audible, sir. Shishnu, sir.
Yeah, I'm audible. Yeah, I can hear your voice.
Shishnu, sir. Hello. Okay. Lakshmikant. Lakshmikant.
Yeah, yeah. Can you hear me?
Problem there.
Hello, can you hear me, Dr. Raghunath?
Yeah. Video on, please. Camera on. Yeah.
Yeah. What is super refractory seizures?
Well, when you try everything and you are not heading anyway in the clinical seizures, then this is a very relative term. It is not like a standard. There's nothing called a super refractory seizures. It is like refractory seizures is sufficient to tell the patient is not responding. Whenever you reach this stage, you already know the mortality is more than 80%. And this is probably, unless you have undertreated the patient and you have done all the modality of treatment and you are not heading anyway, the prognosis is poor. There already is a refractory seizures. There are a lot of terminology can be used for clinical purposes like super refractory or infra refractory. But at the end of the day, the refractory seizures itself is sufficient to tell that patient we are in a very bad phase.
Yeah.
Raghunath sir, I would like to add a point here. In critical care, we are still following the super refractory seizures status definition. Is removed from the as such neurology. From our side, if you use an anesthetic and still the seizures are refractory, the terminology of super refractory status epilepticus is used. Anesthetic infusion, like if you use propofol or ketamine or even midazolam infusion for that matter, or thiopental infusion, we are still using it as, we label it as super refractory status epilepticus.
As per the Neurological Epilepsy Association, each specialty have different modality. For example, emergency medicine physicians, they have a different definition. Neurology will have different definition. Neurosurgery will have their own guideline. So, but overall, refractory, when you have refractory, there is no point of using supra refractory, because if you are used, because we already mentioned about what all things you are going to do, including muscle relaxants, including sedatives, including putting them on coma with using 2 drugs. Sometimes we have used pentobarb and also propofol in the same patient. So as long as patient, you have done everything and patient is already in status, then it's refractory seizure.
Thank you, sir. Sir, I also have one question for you. So we have been using levetiracetam as a first line management drugs everywhere now. We have also, as you said, we have also seen in neurology OPDs that most of them, especially young children, coming with behavioral issues. In ICU, it is very difficult to pick it up. May come it as a delirium maximum in ICU, because most of them are intubated. They won't develop any we cannot pick up such behavioral abnormalities. So what we would like to know is, what is the duration of onset of this behavioral abnormality? So if I start levetiracetam today, when will the behavioral abnormality start? When I should watch for? And second thing is, what is the incidence? And what is the mechanism, and how successful is pyridoxine in treating it, so that we can start off for all patients. This maybe one incidence of delirium comes down if this is the high incidence case.
Sure, a very good question. So I'll just divide them into 2 parts. Number 1 is outpatient and 1 is inpatient. Outpatient, when you start the patient on levetiracetam, within the first week itself, you can see that patient is very angry. A person who is very nice person, like suddenly has become very nasty towards family or any close people, not to other people, but at least to his family members, very difficult to live with and so on. So they come right away within the week and say, oh my God, this guy is like being very aggressive and so on. So at that time, the incidence is less. If you see around, it's less than 1%, but it does happen. And it is one of the most common side effects with Keppra or levetiracetam, the mood manifestation. So by using the pyridoxine 50 mg twice a day, for within like 3 days, they mellow down very easily. So it is very effective. You don't have to stop this, Keppra and switch to other medication. You can just go with, pyridoxine and try it out. Unless it has become really very difficult that he has now physically harmed somebody or something, then you don't want to take a chance. You would switch to something else. But if it's just a little bit of mood disturbance, anger issues and stuff, you can somehow get away with pyridoxine. This is, I'm talking about the outpatient setting. Now coming to the ICU setting, you need to be careful because post-ictal agitation and delirium is very common. I mean, probably 50% of patients who end up with seizures will have they'll be pulling their tubes, they're like agitated, they're all over the place. Do not think that this is due to Keppra. Wait till the patient comes out of extubation, like when he is extubated, see whether patient having some behavioral changes, then you can consider doing this. So giving pyridoxine to every patient might not be the right way. It is not like methotrexate and folic acid. This is more of like, it's a very rare manifestation, but it does happen. So you can reserve that pyridoxine to patients when they develop, mood and behavioral changes.
Thank you, sir. Thank you. So mostly we will see for a week, and if the delirium is not settling and we think levetiracetam is the cause, adding a pyridoxine at this point of time would be a better choice.
Correct. More than delirium, you need to, anger is the major issue. Very angry. I mean, like, I cannot even describe this. They like throw things, they're having tantrums and so on. Those are the most, this one. Otherwise, delirium can be with any medications. It can be due to phosphonitoin, it can be due to, tegretol. Anything can cause delirium. So if delirium is, is aspect, and the pyridoxine is not going to help with the delirium. What it's going to help is especially mood changes and anger issues.
Okay, sir. Thank you, sir.
Yeah. So now we know that the antiseizure medicines are quite, in the sense, have a lot of adverse effects and a lot of drug interactions. So what is your advice on therapeutic drug monitoring of the individual drugs to fine-tune the treatment part?
It's extremely crucial. I mean, without the drug levels, it will be very difficult for a neurologist or a neurosurgeon to kind of adjust the medication dosage. However, given the cost involved and the timing involved of the results to come back and so on, it is a little bit tricky. I mean, I am practicing maybe in the in this kind of scenario, it will be very difficult for me. But if I'm practicing in a developed country, then obviously I need it, because there everything is covered and we get the results within an hour. The dilantin, the levels, the phosphonitoin levels, the valproic acid levels, and most of the tegretol levels and so on. The Keppra levels or levetiracetam levels are very late, even in developed country. So those you can wait. But in this is extremely important, both in ICU scenario and outpatient scenario, to get the levels and monitor the drug.
Yeah. What is it like? The percentage of seizures who are resistant to the medicines what we are currently using to the therapeutic dose, or probably what is the incidence of subtherapeutic medicines being used and labeled as resistant epilepsy? What is your take on this?
So when we don't have the levels, it will be difficult. So you need to use your clinical judgment. So it's well established what is the max dose of each of the drug. For example, levetiracetam, 3 grams is maximum. Let us say we go with the phosphonitoin or dilantin or phenytoin. It is usually around 300 milligram per day, but sometimes in fast metabolizers, we can go up to 450. Once you cross 450, reach 600 per day of phosphonitoin, you are kind of risking toxicity. You need to keep a close watch. So as long as you don't cross the prescribed max dose, even though you don't have levels, that somehow you can manage. If you have the levels, that is great. But if you don't, do not lose your sleep over it. I would use the maximum dose of one drug and then watch for the side effects. And when you combine 2 drugs or 3 drugs, that's when you have a little bit of a problem. It's very easily identifiable because if you look at the UpToDate or any other resources, it already gives which drug does which to your anti-epileptic. So if you choose, let us say, tegretol and valproic acid, it will tell you the tegretol actually metabolizes valproic acid, so or vice versa. So you can use the low dose of tegretol and use the higher dose of valproic acid. So just a judgment call. So that all, it is easily manageable if you just put your mind and and resources into it. Within 5 to 10 minutes, you can solve the mystery. That's not an issue. But if you have the drug levels, that would be the ideal thing.
Yeah, and most of us might have encountered a case of hypoglycemia presenting as seizures or hyponatremia as presenting as seizures. And what is your take? The guidelines say the anticonvulsant need not be administered if there is a reversible cause of seizures. What do you advise on this?
Correct. So if it's a first episode, I've said before, if it's a reversible cause and if it's a first episode, you don't have to treat it. But let us say patient has underlying brain scar, or a patient has AV malformation or something like that, and this was the first episode of seizure, I would commit him for seizure medications. Second thing is patients with neurological damage. The most common electrolyte imbalance is hyponatremia. It can be SAADH from various reasons in the brain. So you need to be careful when you say, well, hyponatremia, I'm just going to correct it and stop there, because you need to take the whole big picture into consideration, because that patient, if there is something, he's going to be in that state for a longer duration, I would still put him on, commit him for seizure medication. Because seizure medications, if you choose one drug and he's responded well, that's not a huge problem, because that medication is safe. And especially if you choose the newer ones, it's not going to give you much of a drug interaction. I would rather have a better protection, and so that he doesn't end up with having seizures frequently whenever he gets either dehydrated or electrolyte imbalance and so on.
Yeah, so based on considering the risk factor the patient has got, we'll decide.
We'll decide, exactly. But one condition where I would say that we are not going to treat the patient, no matter how much he's having seizures, is alcohol and drugs. Because if you have drugs and alcohol on board, no matter what you give, it is because the patient might take that drug and drink alcohol, and it might even kill him. So we are going to tell the patient very honestly and frankly that either you have to choose between alcohol and getting treated. If they say that they do not want to quit, we usually do not even prescribe anti-seizure medications, because it's waste of time, and it will be more counterproductive to give both seizure medications and alcohol at the same time.
And EEG has been used extensively in diagnosing and probably treating seizures. We have some practical issues with EEG. Since it's very commonly done investigation in ICU or probably OPD practice, how optimally you think we should be optimizing the usage of EEG? Like the time, probably the one EEG you do now may not show seizures, the next EEG is showing seizures. So what is your advice? What is the ideal time of getting an EEG done? And what is the duration of the EEG you should actually monitor for not to miss a seizure activity?
Sure. Very important question. So in the acute scenario, in a status epilepticus patient, as I've said before, within 1 hour, I would love to have an EEG, because I want to rule out non-convulsive status epilepticus. There's no question about it. If you are having the ability to do continuous EEG monitoring, that will be great. But in Indian scenario, even in probably corporate sector, I don't think they'll have an ability, because somebody should be there to monitor the EEG. It is not just hooking up the lead and leaving the patient alone. It is just like a heart monitor. You need to hook up, and somebody should be looking at the monitor throughout the 24 hours. So if you just put a heart monitor and nobody's watching the arrhythmia, no point of putting. Same thing with seizure. So if you have a continuous EEG monitoring, there should be a resources that they are looking at the continuous EEG monitoring, because in most of our centers where we have continuous EEG monitoring, there is a tech sitting there in the control room who will be actually having the camera in the patient's room as well as the monitor. So they'll be seeing the patient if he's seizing, at the same time correlating with the EEG. So that's one crucial thing. So in the status epilepticus patient, you need to have the EEG within an hour. In the patient with just one-off episode of seizure, you would kind of do it in the first 24 hours. It doesn't have to be like time sensitive. The sooner the better, but you can kind of have some time. Now, last but not the least is if you feel that patient doesn't have resources, but patient is not seizing and is neurologically stable, you do not have to kind of be nervous about not getting an EEG. You can somehow manage the patient without having an EEG. So it all depends on, if you have it, it's well and good. If you do not have, still we can manage with your clinical judgment.
So because we probably take a reading for about 20 minutes or so of a EEG, probably we might end up probably missing some seizure activity in such.
Regarding the duration of seizure, the minimum time to document a seizure, minimum we have to do EEG for at least 30 minutes. That's the standard. But if you do it for 1 hour, majority of time it picks up most of the seizure. But sometimes due to cost factor or the person's, the technician's, engagement or whatever it is, we might not be able to do it, and the cost will reflect on the patient. So you need to use your clinical judgment. But if the patient is not waking up and clinically you suspect that something is not right, we have done everything we can, but still patient is not waking up, in those patients, insisting on getting a longer read is definitely warranted.
So do you prefer reading the prints of a EEG, or you need an entire 30 minutes EEG?
Well,
there is a technician that
exactly. The technician usually prints out whatever is positive, what he thinks positive, so that itself is sufficient. But sometimes the EEG is very slow, like it's like completely suppressed EEG pattern. So you'd like to see like how much is suppressed, whether there's some burst suppression there or whether there's some activities interim. So, but in majority of the cases, the tech will choose which one to give, and that is enough to interpret.
Technician misses, probably we might miss it.
We might miss it too, yeah.
Yeah, like Dr. was mentioning about delirium in ICU. Delirium is probably one of the very commonly seen issue in ICU, and few of the studies have said about it has got a very poor outcome on a patients who develop delirium. So how should we differentiate somebody who is in say inactive delirium or hypoactive delirium or a non-convulsive status epilepticus? How to suspect and differentiate?
Sure. So when you have a patient who has stopped seizing and now not waking up through their usual course, then you are suspecting that there's something wrong going on. So doing an imaging and an EEG will at least help us out to differentiate whether patient is non-convulsive status or patient is in hypoactive delirium or regular delirium. Because in the delirium, it can be violently delirium, aggressively delirium, or stupously delirium. So or it's a completely just a confusion with just mixing some questions and words and so on. So it depends on the severity of delirium. If the patient is stuporous, then you have to really worry. And you have to make sure that all the electrolytes and metabolic reasons and infections and everything is also at the same time ruled out, including acidosis and so on, so that you will not wrongly attribute everything is coming from the brain and you will wrongly be treating the patient. So when the EEG from neurological standpoint, doing an EEG and also doing a CT or any imaging of the brain will be very helpful in ruling out some of these causes.
Yeah, soft late, there's a lot of discussion on stereotactic surgeries in treating the convulsions. This question is open to both, sir. Dr. Vinayak sir also can comment on this. So what is your take on the surgical interventions to manage epilepsy patient?
Sure. Well, the seizure, especially, there are various other modalities, not just surgery. You have a vagus nerve stimulator, you have ketotic diet, you can have other devices implanted, you can have surgery planned. There is a lot of things can be done in seizure work. However, it has to be done in the very, it is just like cancer treatment. It's a multidisciplinary approach. Epileptologist, a neurosurgeon, a speech therapist, everybody should be getting involved in this decision. They do a test called WADA test. They check the memory, they check the speech to see where the dominant hemisphere is, because they don't want to take off the hemisphere where the memory and the speech is in. So everything is very crucial. So our center, we used to do a lot of epileptic surgery, but by the invent of these newer drugs, the surgical intervention has dramatically compared to the 80s and 70s, 80s and 90s. The incidence of surgeries are going down. So that is good in terms of because there are more effective medications. But I don't know what the scenario here. Dr. Vinayak would be able to tell us more.
Sir, as you told, because of the availability of the liver molecules, the number of cases what we used to give rates at SZCC and NIMANS, the rates of surgeries also, the number of cases has come down after the introduction of these newer molecules like levetiracetam and lacosamide off late. But it needs, as you told, thorough multidisciplinary workup of the patient. If really it is going to benefit, then you subject him for neuropsychological, and then in a committee you take a decision, then plan if really required. That's what we are planning.
Yeah, like you just mentioned, there are many various medicines in critical care practice which influence our anti-seizure medication therapeutic dose or the way it actually supposed to have an effect on the patient. And there are various notorious medicines because we keep using antibiotics very often. I just would like to make this point. So what are like the antimicrobial agents which we should be very cautious in prescribing, especially in an elderly group of patients, which can trigger the seizures or lower the threshold of seizures?
The two antibiotics which you should be very careful, which you would avoid in any seizure patients or in status epilepticus patients, are cefepime and levofloxacin and ciprofloxacin. These are the three antibiotics which can push a patient to status. However, having said that, when you do not have any other choice, then you can treat the patient both seizures and give this medication. So that should not prevent you from doing it. But if you can avoid the ciprofloxacin, cefepime, and the levofloxacin in seizure patients, that would be the best thing to do.
Yeah, like most of our patients are on antibiotics. Probably we should be little cautious in choosing the antibiotics, especially in the elderly patients or patients who have been suffering from seizures. Like sir said, cefepime, imipenem, leoflox, ciproflox are notorious to lower the seizure threshold, including linezolid. Linezolid we don't concentrate much, but it still comes probably in a higher level, which could be one of the reasons which could induce seizures or lower the seizure threshold in a critical ill patient. Yeah, and there is a subgroup of cases like chronic kidney disease patients who are on dialysis or CRRT. As CRRT is coming up in a probably more frequently being used, should we use a higher dose of medicines in such patients, or the current dose of whatever is being used is more than adequate?
So it depends on which drug we are using, because phenytoin and other medications, they don't have any renal implications. So you can use the regular dosage, but if it is a levetiracetam or other which are renally metabolized, then you need to adjust it. There's clear-cut guidelines. If the dialysis patient, you use like the dose which is in the lower dose, and also you do it after the dialysis and so on. So there is protocol for each one of them. It is just very it's not that it's fixed to each of the drug. If the patient has renal impairment versus liver impairment, things change, the dosage changes.
Yeah, just to add to that, like as ECMO is being used, like it also adds to a lot of like drugs getting sequestered in the ECMO circuits. So probably we will have to be a little more cautious, or probably use slightly higher dose than what is being otherwise used in a patient who is on ECMO. Dosing has to be a little cautious, as the volume of distribution and sequestration is quite significant in such cases, apart from our liver failure or kidney injury patients. And again, in renal failure patients, based on GFR, probably will be dosing the medications. Yeah. Any other questions from audience? Are welcome. Like Vinayak sir, would you like to highlight or probably suggest anything in our practice which we need to modify, Dr. Vinayak sir?
I think there is no any change. We are already practicing in a proper as per guidelines. I think we will continue what are the guidelines as per the earlier. They used to do the sodium valproate after the introduction of this lacosamide. Of late, people have almost coming down the usage of sodium valproate. The rest of the things is the same that we are doing. In the Vietnam Institute also, we are following the same protocols at present.
So probably we'll come to the conclusion part. So thank you, Dr. Sushruth sir and Dr. Vinayak sir, for being part of this today's session and giving us your valuable time and enlightening all of us in managing cases of seizures, status epilepticus, fine-tuning of medications, the importance of therapeutic drug monitoring, the adverse effects, how to be monitored and managed, all that. So I again thank everybody who participated in the today's discussion, and we'll conclude it for today. Yeah, thank you. I will be updating about the subsequent discussion topics into your email and WhatsApp. Thank you, everybody. Thank you again, Dr. Sushruth sir, Dr. Vinayak sir.
Thank you.